Hello and welcome to the 2013 WNA Nurses Day at the Capitol webinar series. Our next speaker is Donna Friedsam from the University of Wisconsin Population Health Institute. Donna has worked extensively on access to and financing of healthcare and the organization of delivery systems. She consults widely in the public and private sectors on state government programs and on financing reform initiatives, healthcare quality, and data reporting. Currently, Donna leads a team of faculty and researchers evaluating Wisconsin's Badger Care Plus health coverage program. As director of a health policy group, she oversees the UW's Evidence-Based Health Policy Project, research on healthcare outcomes and disparities, and production of the Institute's e-News and Issue Brief series. She has also served as a lead consultant to Governor Doyle's eHealth Quality and Patient Safety Board and collaborated with the Great Lakes Intertribal Council on developing an NIH-supported Native American Research Center for Health. Donna previously served as executive director of the Wisconsin Primary Healthcare Association, director of a managed care demonstration project, and manager of several projects supported by the Robert Wood Johnson Foundation, the Federal Health Resources and Services Administration, and the Centers for Medicare and Medicaid Services. She holds a master's degree in public health policy and administration from the University of Michigan, Ann Arbor. Please welcome Donna Friedsam.
Okay, so I'm going to talk today about federal reform and Wisconsin health policies, and so the relationship between the two and how the two together might impact access and quality of health care in the state. Next slide. First, let's start by talking about how health insurance might affect health, because that's a question a lot of people have. Why do we focus so much on health insurance? And does that actually have any relationship to the health of the population or to individuals? The Institute of Medicine helped us out with this in 2009. This is the Institute of Medicine, part of the National Academy of Sciences. They looked across all the literature and concluded the following: that a robust body of well-designed, high-quality research provides compelling findings about the harms of being uninsured and the benefits of gaining health insurance for both children and adults. So despite the availability of some safety net services, and safety net services would be like free clinics or hospital emergency departments, there is a chasm between health care needs of people without health insurance and access to effective health care services. And this gap does result in needless illness, suffering, and even death. So we can be sure that working on trying to extend health insurance coverage to people will ultimately have effect on the morbidity and mortality experience of the population. How does this affect children? Well, the benefits of insurance for children are among these: access to a usual source of care for kids, well child care, immunizations to prevent future illness, and monitoring of developmental milestones. They can get their prescription medications as needed. They get, for example, appropriate care for asthma and basic dental services. By the way, did I say it? I didn't say next slide, please, but we are on the next slide. They also, children need health insurance in order to manage any sport, prevent or detect any serious childhood health problems, so they're more likely to be identified early, and children with special health care needs are more likely to have access to specialists who care for those needs. And health insurance allows for timely diagnosis of serious health conditions, and we've seen that children with health insurance will experience fewer avoidable hospitalizations, and they have, for example, improved asthma outcomes and, very importantly, fewer missed days of school, which we have seen correlates to better performance in school and better health overall. Next slide. So adults, those adults that lack insurance, we have seen are less likely to receive clinical preventive services that have the potential to reduce unnecessary morbidity and premature deaths. Chronically ill adults who lack insurance will delay or forgo visits and clinically effective therapies, and this includes prescription medications. They'll either delay or forgo them, or they will at times space out or split their prescriptions such that they're not getting a clinically effective dosage. They're more likely to be diagnosed with later stage cancers, more likely to die from trauma or other serious acute conditions such as heart attacks or strokes, and adults with chronic conditions are more likely to suffer for poor health outcomes, greater limitations in quality of life, and premature death. We also know that the infrastructure and access to primary care is highly correlated with a number of better health outcomes. So in the literature, we've established that areas with better primary care have better health outcomes in the arena of mortality rates, lower heart disease mortality rates, better infant mortality, lower infant mortality rates, and early detection of cancer, among other things. Interestingly, we also have seen that the opposite is the case for areas with higher specialist supply, which actually is associated with worse health outcomes. And I provided a range of citations to show what kind of research this is based in. But what this would suggest is that it's very important for people not only to get access to health care, but to get access to timely, early, primary, and preventive care. And that's what insurance actually provides. Not only does it insure us against major catastrophic losses in the case of severe disease or disability, but it provides us access to primary and preventive services that may otherwise not get delivered or received when people are uninsured and thus rely on just emergency departments or safety net services when things get really bad. So that being said, we want to consider how we achieve better coverage, access, quality, and overall health, and how does Wisconsin go forward in promoting these goals. The goals for health reform overall that I'm sure you've heard elsewhere and are repeated in many different venues and formats is that we do want to expand health insurance coverage to try to get it to as close to universal as possible. We want to improve coverage for those with health insurance so that people feel that their health insurance will help them get the services that they need. Improve access to and quality of health care, and very importantly, we want to control the rising health care costs because we can't continue to pay what we're paying. It will bankrupt everybody, and the more expensive things become, the less ability we have to continue to provide care to everybody, or health insurance to everybody for that matter. The Affordable Care Act was intended to address all of those goals, and to show you here, are we on the slide that says provisions of the Affordable Care Act?
Yes, we are.
Okay. So this is to show you that the Affordable Care Act is a very large piece of law that has a whole range of titles in it that address a lot of different areas of health and health care. And this talk is not going to go into all of that. We're focusing on state law and how the Affordable Care Act affects state law, but just to alert you that there's a lot in the Affordable Care Act, and if you want to learn more about it, there's a lot more to be discussed elsewhere. Next slide. But generally, with regard to providing health insurance coverage and access, the Affordable Care Act goes with a three-legged approach. So let me say, in this slideshow, you'll see the Affordable Care Act referred to as PPACA, which stands for the Patient Protection and Affordable Care Act. You will hear the Affordable Care Act referred to as PPACA or ACA, the Affordable Care Act. The ACA, and you also very commonly hear it referred to as Obamacare. And I will interchangeably refer to it as all those things throughout this talk. So the Affordable Care Act does have a three-legged approach to achieving coverage. And these are employer-sponsored insurance, or the private insurance people get through their employers, also extending public programs, Medicaid, Badger Care in Wisconsin, and Medicare. And in Wisconsin, Badger Care is the children's health insurance program that exists nationally. And then finally, this new form of coverage called exchange coverage, which may be subsidized through federal funds or not, where people can go and buy new coverage. And I'm going to talk about each of these in turn in the next few minutes. First, with regard, as I said, to Medicaid and Badger Care, the Affordable Care Act specified that states need to maintain their existing effort in this arena. Let me say before I go into detail that Medicaid is a state, federal program that provides coverage for people of limited means, and that includes both low-income families and children, and also the aged, blind, and disabled. So I like to emphasize that adults or the elderly that are low income. So the elderly being people over age 65 who generally we think of as the Medicare population. If they're low income, they're also in Medicaid. And most people that are in Medicaid, most people that are elderly and low income and are in nursing homes are also on Medicaid. So the Medicaid program is not only a program for the low income that we often think of as poor families and children, but it's also the program that pays for most people that are in nursing homes. And so essentially the Medicaid program is our program in this country for low-income people and for nursing home care for the elderly and for the disabled. The program is a federal program that's run individually by states, and each state has its own criteria for how to administer the Medicaid program according to certain guidelines that are set by the federal government. And the federal government pays a share of the program costs for each state. In Wisconsin, the federal government currently pays about 60% of the cost, and the state pays about 40% of the cost. And in Wisconsin, we currently have a certain level of eligibility for each different kind of group, given it whether as a child, an adult, an elderly person. And those eligibility levels were set by state law. The federal Affordable Care Act says that the states need to maintain their existing effort in the Medicaid arena as it existed when the Affordable Care Act passed. So what they did not want were states to say, okay, now we have the Affordable Care Act, we're going to roll back our state Medicaid effort and let the Affordable Care Act take care of everything. So they said that states need to maintain current levels of eligibility for adults until 2014 and current levels for children through 2019. And what that means in Wisconsin is that the state needs to maintain coverage for all kids through 2019, and for pregnant women up to 300% of the federal poverty level, and for parents and the caretaker adults, meaning adult grandparents or other relatives that may be taking care of the children in lieu of the parents, or even parent or foster parents or others that may be taking care of children, up to 200% of the federal poverty level. And we did also have a program for childless adults up to 200% of the poverty level, but that program no longer exists. And I'll talk a little bit more about that in a moment. So let me just clarify what these percents of poverty level mean. The poverty level is something that's set by the federal government that says how much a person or a family needs to survive at a minimal level in this country and buy their groceries and have their housing and just get by. And every year the number is adjusted. And what the poverty level is basically 100% of the federal poverty level means the federal poverty level. So currently this year the federal poverty level would be for an individual about $11,500 or let's say $12,000 a year. And for a family of four it would be about $23,000 a year. So when I say 200% of the federal poverty level, we'd be talking about $45,000, $46,000 for a family of four. And when I say 300% of the federal poverty level, we're talking about $66,000 for a family of four, and so on. So when we talk about covering pregnant women up to 300% of the federal poverty level, that means a pregnant woman who does not have other insurance, if she has a household income that's less than about $66,000 a year and she's in a family of four, she can qualify for Medicaid coverage. Or if she's a single woman and pregnant and she has an income that's less than about $35,000 a year, she can qualify for Medicaid. Similarly, for parents and caretaker adults, 200% of the federal poverty level, again, that's going to be about $45,000 for a family of four, or about $25,000, $24,000 for a single person. In Wisconsin, the Medicaid program, Medicaid and Badger Care, covers children with subsidized coverage up to 300% of the federal poverty level, but we do actually provide an opportunity for all kids, meaning that if we have children above 300% of the federal poverty level, but for whatever reason don't have health insurance, their families can actually purchase Badger Care coverage for them, but they just have to pay the entire full price of it themselves. So actually all kids have an opportunity to get coverage through Badger Care. Now, what the federal government said in the Affordable Care Act is that the states need to maintain their existing effort. However, there was this, what they refer to as a hardship exemption, which said that a state can exempt itself from maintenance of effort if it can show that the state has a budget deficit. And so if it has a budget deficit, the state does not need to maintain its effort for adults. And essentially, Wisconsin said this, that, you know, we have a budget deficit, and we as a state do not want to maintain our existing eligibility levels for adults. And so the state has gone through a lot of effort to try to change its existing eligibility for adults while maintaining eligibility for children. So currently, the Governor Walker, has put out his biennial budget proposal for 2013 through 2015, and what he has proposed is several things as it affects eligibility for adults. The first thing he proposes is to reduce the upper income limit for eligibility of adults from 200 to 100% of the federal poverty level. So essentially saying any of the existing adults who are in the program who have incomes between 100 and 200% of the federal poverty level will be removed from the program. And he also says we are going to open the program to allow enrollment for childless adults up to 100% of the federal poverty level. So on the previous slide, if you go back to 2 slides, you see in the middle that it says childless adults up to 200% FPL. Previously, the state had a program for childless adults called Core Plan, where it allowed childless adults to enroll. However, the program was quickly closed because the state did not have enough money to run it. And so there's only about 20,000 people currently enrolled in the program, and there's about 130,000 people on a waiting list for the program. What the governor is saying, we go forward to the slide again, with Governor Walker's biennial executive budget proposal, the governor is saying he will open up the Core Plan enrollment for childless adults, but not to 200% federal poverty level, but rather up to 100% of the federal poverty level. So he's saying all adults under 100% FPL can be Medicaid eligible in Wisconsin, and no adults over 100% of FPL will be Medicaid eligible anymore in our state. And in doing so, what the governor's administration estimates is that 87,000 currently enrolled parents will lose their Badger Care Medicaid coverage, and in exchange, 82,000 childless adults will gain their Core Plan coverage. So this results in a net reduction of overall enrollment of about 5,000 people. Let me say also that when I talk about childless adults, we're talking not only about people that have never had children, so that may be young adults who haven't yet had their children, or people who've chosen never to have children, but we're also talking about adults who had children, but the children have aged out of dependency. So their children are themselves now adults. So we're talking about people in their 40s, 50s, and 60s who have had their children are no longer dependent, and these people themselves are older adults but not yet Medicare eligible. So here's the next slide, please, with the chart, shows essentially the effects of this. It shows that children would remain eligible in Wisconsin for Badger Care. Pregnant women would remain eligible up to 300% of the federal poverty level. And that the green part shows that parents and caretaker adults would remain eligible under 100% FPL, and adults without dependent children would also have eligibility under 100% FPL. But those adults who are currently eligible up to 200% FPL would no longer be eligible. And instead what the governor says is he's going to send those people to go buy their own insurance, private commercial insurance, through these health insurance marketplaces, or what's called exchanges in the Affordable Care Act. Next slide. So what the governor says is that if we do this, there'll be an overall reduction of about 225,000 people who are currently uninsured. he says that this many people will gain insurance based on the assumption that those who are no longer eligible for Medicaid will purchase coverage through the Affordable Care Act's federal exchange. So this projection of 225,000 includes the number of people who will get new coverage through the Obamacare subsidies, and also the people who he's taking off of Medicaid coverage and sending to get Obamacare subsidies through the exchange. The Legislative Fiscal Bureau, which is a nonpartisan financial projection organization that's linked to our legislature, provided its own independent estimates of the governor's plan, along with other eligibility scenarios that Wisconsin might consider. And what the Legislative Fiscal Bureau said is that compared to the governor's plan, if the state were to pursue the Affordable Care Act's eligibility options, let me back up. The Affordable Care Act provides that every state can bring all adult income eligibility up to 133% of the federal poverty level. And so basically the ACA says, rather than having all these different affordability levels at every different state, the federal government says every state should bring all adults and children, for that matter, to at least get covered if they're below 133% of the federal poverty level. And so what the federal government says is, in order to make that happen, if states expand their Medicaid programs, the federal government will pay 100% of the costs of those expansions. So all the newly covered people will be paid for 100% by the federal government for the first 3 years of their coverage. And then after that, the rate of federal cost sharing will decline gradually till it achieves 90% cost sharing by the year 2020. And continue at that 90% cost sharing thereafter. Now, that 100% cost sharing in the first 3 years and then 90% cost sharing is a very favorable rate of cost sharing, because currently the Medicaid cost sharing, as I mentioned earlier, is 60% in the state of Wisconsin compared and a 40% state share. So what we're essentially looking at is 100% federal share in the first 3 years and then going to a 90% federal share thereafter. A lot of people see this as a really good deal and a lot of federal money that could come into the state at no cost to the state taxpayer in state revenue. Governor Walker says he doesn't trust the state that federal Medicaid match is actually going to materialize as they're promising, and he doesn't want the state to depend on that. He also says that he does not like to have people in Medicaid because that's a public program, and that he'd rather send people to get private coverage because people are better off in private commercial insurance. Now, Governor Walker's points about private insurance are based on a couple of things. Private insurance does pay better rates to providers. So a doctor or a hospital will get paid higher payments and prices from a private insurer than they will get paid from Medicaid. And so the providers like that better, but it also does benefit the patient in that the patient will have an easier time finding providers that will take care of them. So there are reasons that it may be better to have people covered in private insurance than in Medicaid, apart from what you think about, what you may or may not think about whether people should be on public programs or private programs. Nonetheless, if we just look at how much it's going to cost the state in terms of state dollars and federal dollars, we can look to the Legislative Fiscal Bureau and ask them, well, what do they say? And the Legislative Fiscal Bureau did provide estimates, and what they said is, compared to the governor's plan, adult income eligibility at the level set by the Affordable Care Act of 133% federal poverty would require less in state revenue or state tax dollars and would bring in a lot more federal revenue. it would also result in larger overall Medicaid enrollment. So essentially what they're saying is a lot more people would be covered by insurance in the state. We'd get a lot more in the way of federal money coming into the state, and it would require less state tax dollars to make it happen. What's the other side of that, though? The larger overall Medicaid enrollment is matched by smaller enrollment with private insurance. And that's the part where the governor has a ideological difference. The governor says he does not want larger overall Medicaid enrollment. He wants people in private insurance. The big question is, next slide, whether people are actually going to get that private insurance if they get taken off of Medicaid coverage. So there's a couple of concerns, or a number of concerns people have raised about the governor's proposal. First of all, one of the concerns is that employees who are without what's called affordable employer health insurance. Currently, the Affordable Care Act specifies that if there's employees who do not have access to what it defines as affordable health insurance, those employees can go purchase their coverage through these federal exchanges that are going to be set up. And the employer will have to pay a tax penalty for not providing affordable insurance to their employee. So the employer then, when an employee goes and buys that insurance through the federal exchange, the employer will have to pay a $3,000 tax penalty. If those employees had been Medicaid eligible, those employers would not have faced that tax penalty. So for all those people that are being taken off of their Medicaid eligibility and sent to the exchanges, the employers are now going to be facing a tax penalty that they would not have faced previously. In addition, there is uncertainty about how many of the low-income people, the people between 100 and 133% federal poverty, or even up to 200% federal poverty, how many of them will be able to afford the premiums and the cost sharing of the private plans that are in the health insurance exchange marketplace. So Medicaid comes to people at a fairly low cost. There's very little cost sharing associated with Medicaid. And even people, even though there is some premium participation that rises with income, it doesn't come to close to what they might experience when they have to buy private health insurance in the marketplace, and then the kinds of cost sharing that's associated with that. And a number of people have expressed concerns about whether the very lowest income people near the federal poverty level are going to be able to afford that kind of cost sharing. And if they can't, or if they choose not to, then instead of gaining insurance, those people are going to go from Medicaid and become uninsured entirely. Because of these concerns, even the Wisconsin Hospital Association has called for a 2 to 3 year delay in implementing the governor's proposal, and has said that it's very concerned about the potential increases in the number of uninsured that we might be facing under this proposal. And our recently departed Department of Health and Service Secretary Dennis Smith, who left his post last week, did announce in a number of interviews that this plan would not take effect if the health insurance exchanges were not operational by the end of the year as planned under the Affordable Care Act. So what this shows is how important the health insurance exchanges are going to be in order to make this plan viable. Because the governor is sending people who currently have Medicaid and saying, in order for you to continue your coverage, you're going to need to buy that coverage in these private health insurance exchanges that are being set up by the federal government under Obamacare. At the same time, the governor has said, we don't particularly support the Obamacare, and we don't particularly support having a federal exchange. In fact, the state is not participating in the development of an exchange, and has basically said, we're going to let the federal government do it and run it, and we're not going to do that at all ourselves. So the question that has been raised is whether we're actually going to have a fully operational exchange in Wisconsin, and how many affordable health insurance products are going to be available in that exchange. So now they've said, if there's not a good operational exchange, this plan will not take effect. So this shows that there's a lot of question about whether this is even a viable plan at the moment. Next slide. I'm going to skip this slide for now, except to say that there was a provision in the governor's budget that would have had the effect of reducing the scope of coverage for pregnant women who are between 133 and 300% of the federal poverty level. It would have moved them from full coverage to limited prenatal care. The administration is now stating that the effect of this provision was not intended and that it has pledged to maintain full Badger care coverage for this population. So presumably this is not going to happen, and pregnant women will maintain their full Badger care coverage, but it is something that I put in there in order to alert people that it's something they're going to want to watch and keep their eye on. So this next slide shows the status of state support for the Medicaid expansion. As of March 1st, 2013, you can see that 24 governors have supported the expansion, and others are either undetermined or not participating in the Medicaid expansion. A lot of this does fall out according to party lines into the Democrats and Republicans, but not entirely. So you can see in the upper Midwest here that we have many of the states around us are participating in expanding their Medicaid programs, including Michigan, that has a Republican governor, and then, of course, our neighbors to the south, Illinois, and Minnesota over to the west. And Florida, with a Republican governor, is going to participate in the Medicaid expansion, and Arizona out in the west. And states have all their own particular reasons. And then most recently announced New Jersey under Republican Governor Chris Christie, as well, is going to participate in a Medicaid expansion. So I believe at this point we have 9 Republican governors who have announced that they will participate in the Medicaid expansion. But Wisconsin governor has chosen this different path. And so we'll see how this all plays out over the next few months as our legislature considers his proposal. Next slide. So what about private commercial insurance? We have to consider what's going to happen under employer-sponsored insurance, individual policies, and these health insurance purchasing exchanges that I keep mentioning. Next slide. The Affordable Care Act did build itself on a base of continuing the current system of employer-sponsored insurance. So you can see in this slide that without health reform, we would have continued with our current system where about a little over half of the population gets their coverage through their employers or through their spouse's employers, their parents' employers, or some other connection to employer-sponsored insurance. But here it shows that it would have been about 57%, and currently about 55% of the population gets their coverage that way. The changes that would exist with the Affordable Care Act were projected on the right-hand side of this slide to say it wouldn't have changed much. Pretty much it's built on a base of employer-sponsored insurance, and the difference is that a lot more people will be moving from the uninsured status into what these private coverage through these exchanges that I'm going to talk about, these marketplaces, and also a lot more people moving into Medicaid coverage, such that we have a significant reduction in the number of uninsured. The big debate that we see around the Affordable Care Act, among many, is that the people that oppose the Affordable Care Act do not believe these numbers and are of the belief that many more people are going to move out of this employer-sponsored insurance and into the category of Medicaid, and they do not like that. They do not like the idea that more people are going to move into a publicly sponsored program and off of employer-sponsored insurance for the reasons I noted earlier. Next slide. I think I'll skip this slide because I already discussed these issues and go on to the next slide about employer requirements and incentives. So the Affordable Care Act does have several provisions to get employers to provide insurance to their employees. It specifies that larger employers that don't offer affordable coverage will pay penalties of up to $2,000 per full-time worker per year. Now, before you heard me say something about $3,000. What does that have to do with? That has to do with if larger employers do provide insurance to their employees, but employee finds that the insurance is not affordable to them, then the business will pay a federal pay $3,000 for that employee that goes instead to get federally subsidized insurance. So we have a range of penalties for employers between $2,000 and $3,000. Now, these penalties do not apply to small employers with up to 50 employees. Those employers are exempt from penalties. And there are some tax credits available for some small businesses that offer health benefits. So these are the provisions. There's a lot of concerns associated with what kinds of incentives this may or may not provide for employers, such that some employers may reduce their workforce to get just below that 50 employee line. If they currently employ 52 employees, they may say, you know what, I'm going to go to 49 employees, so I'm not subject to these provisions, or they may decide not to move some of their full-time employees to part-time employees, full-time being defined as 30 hours per week. These are all concerns that we are not exactly sure how they're going to play out, but this is how the law stands currently. Next slide. The individual mandate in the law says that individuals will be required to have health coverage that meets minimum standards in 2014. And this provision is intended to spread the costs among the whole population. So the idea here is that people will no longer be able to go and hide out from the potential risk that's available that might present itself in the future. So the idea is that the healthy younger people will share in the costs of the less healthy people, with the idea that eventually the healthy people are going to have health needs themselves one day, and that we're all kind of in the same risk pool together. And once we get into a larger risk pool, all of our rates come to some more average affordable levels. So the older or the less healthy people have lower, more manageable rates, and the healthier people are going to have to pay a bit more, again, for sharing in the risk and knowing that someday when they have health needs, they're going to still be able to afford their insurance. So this is the idea of no longer segmenting the population according to their risk, but rather having everybody sharing the risk together. So why is it an individual mandate? Why do people have to get insurance? The idea here is that people will have to buy insurance because the Affordable Care Act also says that insurance companies cannot deny coverage based on pre-existing conditions. It says that the Affordable Care Act says that insurance companies must provide insurance to people when they come to purchase insurance. So if it said that and it did not have a mandate, it would then essentially it would have the effect of having only people that have health needs going to buy insurance, and everybody else would say, well, I'm not going to buy insurance because I don't have any health needs. And what would happen then is that insurance would be very, very expensive because it would only be for people who have all these needs. And you or I could go wait, and then the day that we have some kind of problem diagnosed or some kind of an accident, then we'd show up at the hospital and we'd say, oh, and where do I buy my insurance today? Just like you don't buy insurance for your house until your house is on fire or some such thing. It would not be a workable system for insurance. And so the only way to make insurance companies have to provide insurance for everybody, regardless of their risk and regardless of their condition, is to say that we're going to give you a lot of healthy people in the risk pool too to balance out the risk. So this mandate is enforced through the tax system. So when people file their taxes every year, they're going to present proof of insurance or proof of why they're exempt from the mandate. There will be penalties for not having insurance, and there are also exemptions for certain groups and if people cannot find affordable health insurance. Next slide. What are these health insurance exchanges? So starting next year on January 1st, individuals and small businesses will be able to shop in a new health insurance marketplace. And it's pretty much like you see here in the picture. People are going to be able to look like they're going shopping and finding the standardized insurance products and have tools for comparing options and finding the best plans, and there will be strong insurer oversight. So basically what these exchanges are I compare them to kind of a shopping mall where in order for the health plans to do business and open up a shop in the mall, they have to agree to abide by certain rules. And in order for them to sell products to the people that shop in the mall and get access to all those customers, they have to sell the products according to certain rules. And then the customers who come to the mall can come and buy the products knowing that the products have certain guarantees and certain quality standards, and the customers that come to the mall then are provided federal subsidies to purchase the coverage depending on their income. And subsidies are available depending on their income, such that anyone between up to 400% of the federal poverty level can get some degree of subsidy to purchase their health insurance through the exchanges. Next slide. There's also going to be small business exchanges set up that will enable smaller companies to offer a selection of affordable health plans. So today, a very small business may only be able to get one company and provide to provide insurance for their employees. And in addition, if that company, if that small business, let's say it's a local retailer on your main street, has one person that ends up having cancer or a child with a severe condition, the rates for that little business is going to go sky high, because the only people in that pool are those 4 or 8 or 10 people. With these exchanges for the small businesses, basically they're combining a whole bunch of small businesses together to make one big giant risk pool. And so no longer is this the case where the small businesses are at such the mercy of the insurance companies' change of premiums. So now they have more stability in their rates. Even if they do have a person or a couple of people in their group that have health problems, they share the risk pool with enough other people broadly that the premiums will remain stable. And in addition, because they're bringing enough customers to the group, they'll get a number of insurance companies that will offer them options for products instead of just one single insurance company. And as well, as I mentioned before, there will be tax credits available to reduce the premium costs for small businesses and workers. Next slide. So the Affordable Care Act offered the states the option of either setting up their own exchanges or saying they're not going to do it and they'd like to defer to a federally run exchange. And this slide shows what the states decided. And you can see that Wisconsin said, we're not going to set up our own exchange, we're going to just let the federal government do it. And and you can see that by this slide, that this pretty much broke down by party line in terms of governor's control of the states. So for the most part, states with Republican governors are deferring to a federal exchange, and states with Democratic governors said, we will run our exchange. Essentially, what this showed was the Republican governor said, we are not in favor of the Affordable Care Act, and we don't want to participate in it, so we're not going to run an exchange. So, and that's the case in what happened in Wisconsin. But you can see that the surrounding states in our upper Midwest, for the most part, besides Indiana, are either running their own exchanges or they are going to do it in partnership with the federal government, including Michigan with its Republican governor. So there are a few exceptions. Utah, with its Republican governor as well, will run an exchange. But for the most part, it did break down by partisan lines. So in Wisconsin, we're going to have a federally operated exchange where people, rather than going to the Wisconsin exchange, will be sent to the federal exchange to purchase their insurance. Next slide. In addition to all these coverage provisions, there are provisions in the Affordable Care Act addressing other aspects of health reform and delivery system change. There are provisions associated with promoting primary care and prevention, improving provider supply, developing new models for coordinating and delivering care, making use of health information technology, and reforming provider payments to promote quality. I'll talk about each of these a little bit in a moment. Next slide. So with regard to addressing health care costs, the Affordable Care Act provides greater oversight of health insurance premiums and insurance practices. It works to increase competition and price transparency through these exchanges, as I mentioned. It does have some provider payment reforms in Medicare, and it provides some opportunities to test new and more efficient delivery system models in both Medicare and Medicaid. Next slide. In terms of addressing provider supply and capacity challenges, again, there is a concern, how are we going to care for all these new people that are coming to get primary and preventive care that previously were uninsured? The Affordable Care Act does have some significant changes in the allocation of graduate medical education training slots, so those are the slots for medical residents, to emphasize primary care in outpatient settings. It has grant funds to support community health workers. It supports telehealth in areas of behavioral health and the treatment of people with chronic illness, and in particular by non-medical providers. And it has increased requirements on nonprofit hospitals to identify and meet community needs. Next slide. It also has new funding streams for the recruitment and training of a more diverse workforce, for the expansion of federally qualified health centers. It provides federal grants to states to test alternatives to the current medical liability system, and it expands on loans and repayment options for professionals that are going into healthcare in underserved areas. As well, there's a number of states that are working on modifying scope of practice laws and credentialing of medical professionals, and I know that this is of particular interest to nurses and advanced practice nurses, and that your state nursing association is very active in this arena. Next slide. In terms of promoting prevention and primary care, it does increase Medicare and Medicaid payments for primary care providers. It has incentives, as I noted, for new doctors and other health professionals to practice primary care. It removes cost sharing in Medicare and in new private plans for certain preventive services, and provides incentives for states to do the same in Medicaid. And as well, finally, the Affordable Care Act does provide funding for population-based prevention activities. Next slide. The Affordable Care Act also has a fund called the Public Health and the Prevention and Public Health Fund that supports various programming in the arenas listed on this slide: breastfeeding, oral health, etc. So it does address a whole range of arenas intended to support wellness and prevention in addition to the delivery of medical care. Next slide. Now, how does this relate to what's going on in the state and the governor's biennial budget? Well, Governor Walker did put into his budget proposal a significant package associated with mental and behavioral health. And you can see the provisions here, several $1 million over the biennium to fund inpatient units at the Mendota Mental Health Institute, for coordinated service team expansion, for comprehensive community service programs, $1.3 million to establish peer-run crisis centers to support the cost of in-home counseling for Medicaid patients, and also establishing an Office of Children's Mental Health Services. So many people applauded this effort. This effort was associated with the state's response to the dialogue at the national level around mental health that kind of arose following the gun violence incidents of the last year and the last several months. And there is some debate about whether this effort in mental health is sufficient to the discussion that needs to occur in the state around gun violence and violence prevention. But nonetheless, people are very pleased to see this emphasis on promoting mental and behavioral health. Next slide. The governor did put in a very substantial package around the health professions workforce in terms of the expansion of medical and graduate medical education. You can see here a number of provisions in the magnitude of millions of dollars for advancing medical education in rural and urban areas, supporting new medical education initiatives in Wausau and Green Bay, and both medical education and graduate medical education, and also an expansion of Fair Market Dental School. What you don't see here are specific initiatives in nursing education. Next slide. With regard to other non-medical education initiatives, what I was able to find in the governor's budget that may be relevant to nursing education was the $2 million allocated to the UW system to start a flexible degree program. And the language about this was to allow people already in the workforce to get degrees in programs such as nursing, information systems, or medical imaging more quickly by getting credits for knowledge they learned on a job or through online courses. So at this point, that's what I was able to find in the governor's budget that may be of specific relevance to the to nursing careers. Next slide. There are provisions in the budget around the expansion of certain reforms in the delivery of medical care and health care generally, and this initiative called medical, or also called health homes, is expanded such that he calls for the continuation of Medicaid medical homes for high-risk pregnant women and expanding it to additional high-risk populations. He also wants to provide care under this framework to foster children and to the fee-for-service or SSI population, which would be the disabled population in the Medicaid program. Next slide. And there is a substantial provision for $5 million to promote what they refer to as consumer engagement over the biennium through the Wisconsin Health Information Organization. This is intended to increase transparency of the cost and quality data and help with consumer education around the costs of healthcare and the quality of their providers. So the budget language does include specific projects around a consumer-based website to compare health insurance options, statewide programs to increase health literacy, information technology enhancements, and quality improvement activities. Next slide. Some other provisions of interest to nursing may be the $11 million capital budget request to support new facilities in Milwaukee and Madison that serve victims of domestic abuse. And then there is a small allocation, $190,000 a year, for the Group Insurance Board to expand current wellness programs. And that would be the board that oversees state employee insurance programs. And it also calls for that board to implement a tobacco use surcharge for state employees beginning in 2014. And this provision has brought a debate about its potential effectiveness. So, next slide. What we see, let's go to the second bullet on this slide. Health First Wisconsin, which is a prevention group in the state, has actually come out in opposition to the proposal to penalize state employees who use tobacco. This group and others have said that tobacco causes addiction. It says addiction here, it should say addiction, and that the proposal penalizes tobacco users, can deny health insurance to those who need to quit, and that this approach is not evidence-based. So instead, Health First Wisconsin and some other groups have called for some different approaches, and that's the first arrow on this slide. They're calling for the legislature to close the tax loophole that allows so-called little cigars and other non-cigarette tobacco products to be taxed at a much lower rate than cigarettes. And finally, there's a non-budgetary proposal currently in the legislature called the Healthy Jobs Act that calls for tax credits to small businesses to cover 30% of the cost of employee wellness programs. And this is sponsored by Senator Terry Moulton. Next slide. In terms of health reform implementation, this provides you a timeline of what's already occurred and what's due to occur in the next year. We've already seen some insurance market changes, the elimination of cost-sharing for preventive services, allowing dependents to remain on their parents' coverage through age 26, the elimination of lifetime caps on insurance, elimination of pre-existing condition exclusions, small business tax credits going into effect, premium review going into effect. In the coming year, everybody's getting ready to open up these exchanges as of January 1st, 2014. So what will be important to keep your eye on in the coming year is that as of October 1st, the exchanges are supposed to open for open enrollment. So people who are currently uninsured and not eligible for other insurance or don't have access to affordable insurance through their employers or elsewhere will be able to apply for open enrollment in the health insurance exchanges and to get subsidized federal subsidies to purchase those exchanges. So there's a lot of activity right now around that, and also the development of a whole system of support, including navigators, to help people understand what their insurance options are. So you're going to be seeing that, as well as the current debate in the legislature around what to do around Medicaid and the eligibility levels associated with that. Next slide. That's my contact information, and I'd be happy to answer further questions as people want to contact me with them. Thank you.